Shimasaki received his BS in biochemistry from the University of California at Davis, his PhD in molecular biology and biotechnology from the University of Tulsa, and his MBA from Northwestern University Kellogg School of Business. He is an adjunct professor at the University of Oklahoma and is the co-founder and CEO of Moleculera Biosciences, a neuroimmunology precision medicine company focused on identifying and treating the underlying roots of neurologic, psychiatric, and behavioral disorders triggered by an autoimmune response. He has spent over 35 years working in the fields of molecular biology, viral pathogenesis, and infection-triggered autoimmune neuropsychiatric disorders. Dr. Shimasaki started his career at Genentech and has worked across all stages of research, development, clinical trials, and regulatory approval of technology innovation from bench to bedside. His research work includes epitope mapping of HIV proteins, genetic-based predictors of breast cancer risk, influenza and RSV diagnostics and therapeutics, and the pathogenesis of infection-triggered neuropsychiatric disorders. He has co-founded multiple companies and led multiple products through the FDA approval process and is a co-inventor on multiple patents. Internationally, he teaches and mentors scientists, physicians, and biotech leaders on how to translate their research into acutely needed medical interventions. His passion is to translate scientific discoveries into acutely needed products so that more patients can live longer, healthier lives.
Thank you all for joining today. What we're going to do is we're going to walk through what I believe is going to be and continues to be some of the most interesting emerging areas of medicine, and that's the connection between the immune system, the brain, and then also infections. And I'm going to talk a little bit about some of the other research that we're doing here at Moleculera Biosciences. But let me go and give you a little bit more background on really the biology. So I think it might help as you see your patients and you work with patients, but also as you see the emerging information coming out in this field of medicine. So what are we going to cover today? We're going to talk about how infections can trigger neuropsychiatric disorders or neuropsychiatric symptoms, and then why do certain infections trigger these immune-mediated neuropsychiatric disorders? You've probably heard of PANDAS and PANS, maybe neurologic Lyme, of course, long COVID, but these are medical models, as we'll talk about, for more and other chronic disorders that have a similar type of pathophysiology. We're going to talk a little bit about the symptom correlation between these biological targets, and what we have is the autoimmune brain panel, and we're going to talk about how they can aid in the diagnosis and helping to direct treatment. And then we'll wrap up with some case studies of patients and therapeutic treatments that have been showing clinical efficacy in treating these immune-mediated disorders that are secondary to infections. So as Amy said, if you have a question too, don't hesitate to put that in the chat. We'll come back to that and we'll be able to answer as many as we can. Hopefully we'll get the majority of them all covered at the end. So let me start out by, we all understand that infections can directly contribute as an infectious etiology to things like cardiovascular, neuropsych, chronic fatigue, cognitive brain symptoms, etc., as a direct infection, meaning where we'll see maybe infectious or viral encephalitis or other types of things. Those are known, and often they are rarer, but we're talking about today is this indirect effect that is quite more frequent and more common. And this is related to the immune system function as it's related to what we'll call a dysregulated or a misdirected immune response. Because it does affect treatment decisions, because there are different treatments that are going to be effective when you're looking at one that is an indirect immune dysfunction versus the other that is a direct infection. And we'll talk about how those things are related. So sort of the summary there is a complex, but there is a direct interconnection. And we're going to talk about that in detail about how infections and even some non-infectious triggers that impact our body and result in impacting our immune system through what we're going to talk about is autoimmune antibodies, inflammation, but even microglial activation, cytokines, mast cell activation, and how that impacts brain function. And yet they are all connected in this genetic predisposition immune system dysfunction in a susceptible individual. So let's talk about that in a little bit more detail. Worldwide, the problem is that over 800 million individuals have some association or suffer from various types of these neuropsychiatric and behavioral disorders. You're going to recognize many of them, and there are many others that are listed in the DSM-5. But the thing to note is that these disorders are diagnosed by clinical symptoms rather than biology. So, for instance, if an individual exhibits motor or vocal tics for longer than 12 months, that's the basis of what's diagnosed as Tourette syndrome, irrespective of the underlying etiology or the biology. And as a result of that, patients are typically treated for the symptoms rather than addressing an underlying root cause. And therefore, what happens is anywhere between 20 to 60% of these patients are what's labeled as treatment resistant to these symptomatic treatments, neuropsych drugs, psychiatric medications, various things, because the root has not been identified and the treatment is based on the symptoms. Now, one of the things that has been helpful is that we know that the standard of care for these neuropsychiatric disorders is treating symptoms, and often, in many cases, the underlying root can be addressed with psychiatric drugs for antipsychotics, antidepressants, stimulants, mood-altering drugs, etc. But for the patients that we're going to talk about who are immune-mediated, these do not help them. In fact, often what you'll see is they will actually get worse. And of course, we do know that there are deleterious side effects for many of these medications. So there's a risk of, and many have black box warnings about side effects that can either worsen or cause additional symptoms. Psychotherapy is another modality that has been used and is effective for certain individuals. Unfortunately, those that are not responsive tend to actually end up institutionalized. So let's move over to the question, can infections trigger an autoimmune response that leads to neuropsychiatric disorders? So growing bodies of evidence, and this was published in JAMA Psychiatry in 2019, where the Danish group followed over 1 million individuals for their medical records from the time of their birth to 18 years of age. What they found was a surprising correlation that if an individual was hospitalized for a severe infection, they noted that the risk of developing a mental disorder increased by more than 80% for schizophrenia, autism, OCD, ADD, ADHD, oppositional defiance, tic disorders, personality and behavioral disorders, and many others. So, in an editorial that accompanied this article, the question was asked, how could exposure to infections affect the brain mechanistically and give rise to mental disorders? What they said was circulating autoantibodies that enter the brain via a compromised blood-brain barrier, bind to neurotransmitters is a potential explanation. And that mechanism has been proposed in pandas and other mental disorders. And this is exactly what we're going to talk about, this pathophysiology that begins with an infection that leads to the symptom manifestations. Because a large portion of these disorders are truly caused by infection-triggered autoimmune dysfunction. So if we step back and we look at the biology, what is really going on? Well, it's true that we know that everyone, and nobody's immune to that, encounters bacteria, viruses, fungus, other types of infections. And our body goes through a process through our innate and our adaptive immune system and begins to develop antibodies that will recognize these infectious organisms. So what happens here in those that end up with these neuropsychiatric syndromes? Well, the antibodies that they develop cross-react with various neurologic receptors through a process called molecular mimicry. This is an old term that's been around for a long time, and it's been one of the most, what I believe, is the underlying reasons that is a result of autoimmunity, other types of triggers, and especially what we're going to talk about in neuropsychiatric disorders. They then cross the blood-brain barrier through what we might think of as friendly fire. They interfere with various receptors and different types of neurologic targets, hence resulting in these symptoms that are described here. And if you recognize that typically these patients will be put on psychiatric medications, but as mentioned, these are treatment-resistant patients because the underlying root is not a deficiency of SSRI. Patients then who are treated with immune modulators, anti-infectives, and anti-inflammatory agents then experience remarkable recoveries. So let's look really at the inflammatory process, because inflammation, the immune system, which is responsible for creating the inflammatory process, is a good thing. And actually, acute inflammation is what helps us stay healthy. So when we get insults, infections, trauma, etc., it's the signal for our immune system to begin to work, begin to eradicate whatever the agent is, begin the healing process, and recruit the different parts of the immune system to begin the healing process. Now, there's a difference between that and a chronic inflammation. The chronicity of inflammation over time leads to autoimmune diseases, even cancer, cardiovascular disorders, and even now Alzheimer's is believed to be a very long process in which the inflammatory process and the immune system becomes continuously elevated such that it leads to these tangles in the plaques. And many believe now that those are immunopeptides. What we're going to talk about today is the psychiatric and behavioral disorders that accompany these patients. So we all know about long COVID, but it's now understood that long COVID is really the effect of a virus or portions of the virus and the virus protein that is triggering the immune system to be directed against the brain, the heart, the lungs, the blood vessels, and other organs that lead to these chronic disorders and symptoms that are multifaceted. And so again, you can see the connection, an infection, the immune system directed against specific tissues and organs that result in the chronicity of these different disorders. And there is a growing recognition that I mentioned of the connection between infections, the immune system, and Alzheimer's. In fact, it's no surprise really, because of the literally hundreds of failed clinical trials for attempts to have drugs that eradicate or get rid of or the tau and the amyloid plaque and the tangles. And then now recognizing that this is an immune process that begins many, many years prior to it. In fact, could be even decades. Well, how does the difficulty in diagnosing these patients become exacerbated? One of the great things about the medical system is that we do have specialization, where it allows us practitioners, clinicians, researchers to be able to focus in certain areas. But the prevailing model of disease biology is not segregated, in which infectious diseases do affect the psychiatry, psychology, neurology, immunology. And so what we see is that in order to be able to be successful in helping these patients recover, there needs to be some type of cross-disciplinary collaboration in the medical care. And that can help accelerate the diagnosis, and the underlying treatment of chronic disorders. So that's an important aspect as you work with other clinicians and work with other researchers or work with other groups in different areas of specialties, that these are important to be integrated. So one of the things that we find in a typical patient journey, and this is something that we're working on a burden of care publication, is that the patients that we've seen, now over 16,000 of them, on average have been searching for a correct diagnosis from anywhere between 3 to 7 years and have seen between 5 to 15 different clinicians. And we find that they've spent somewhere between 20 to 100,000 or more on visits, medical testing, ineffective treatments, and even care for themselves or their children. In that survey, some of the write-ins these patients or their parents wrote in were really heartbreaking. You see the difficulty and the challenges, both financially and socially, and just as far as just being able to take care of or find answers. And so look for that. We hope to be able to produce that and publish that here in the near future. So what that gets us back to is that it's important to have precision diagnosis to accelerate the effective time to treatment. Because patients with similar symptoms, as mentioned, standard treatments are ineffective somewhere between 20 to 60% of the patients. We're going to talk about these anti-neuronal antibodies, and these are more common than some of the ones that you might have heard of, such as the GAD65, the NMDAR receptor, many of these aquaporin receptor autoantibodies, which are present and do cause various severe neuropsychiatric symptoms, but they're not as common as these. So what we can do through these testing is to be able to identify patients that are immune mediated, whereas they would then respond and be treated with immune modulators, anti-inflammatory agents, and anti-infectives, as opposed to those who are not immune mediated, where they respond with the traditional psychotropic medications. So you may have heard of PANDAS and PANS, and PANDAS is a disorder that's, the acronym stands for Pediatric Autoimmune Neuropsychiatric Disorder associated with a streptococcal infection. And we're grateful to Dr. Susan Sweeto, who pioneered this back in the 1980s, and then published in the 1990s. The first 50 cases, and what she had found was that there was a group of patients who came to her who had sudden onset of obsessive compulsive disorder and were preceded by a streptococcal infection. So the mechanism of these anti-neuronal antibodies, which we're going to talk to in more detail, is that they interfere with receptors in the brain. And so antibodies then is again crossing the blood-brain barrier, interfere with, in this case, some of these pre and post-synaptic neurologic receptors here, and then cause and trigger many of these symptoms, as what we've done and published in multiple journals. There are 5 targets that we're examining in which they're directed towards. The other publication that we and our collaborators have published is that in the central or cerebral spinal fluid, you can find these same autoantibodies that are in the serum. And in fact, here this study showed almost 95% correlation with autoantibodies in the serum correlated with them present in the cerebral spinal fluid. Again, remembering the JAMA Psychiatry paper, that there has to be a breach in the blood-brain barrier, and these cross the blood-brain barrier. And typically in diseased patients, you'll see that. So if you look at some of the other data and some of the publications showing that autoantibodies that attack the basal ganglia and trigger inflammation in part of the brain, especially in patients and children with OCD, tics, associated with a strep infection, that you can see the elevation in the volume of the caudate, the putamen, and the globus pallidus, which are all parts of the basal ganglia, but not in the thalamus, which is not part of it. And we do know biologically that the basal ganglia is responsible for motor control, learning, cognitive functions, emotional functions, and eye movement. So I took those functions and placed them over what's known as the PANS-PANDAS criteria. And if you look at that criteria, what you can see is that anxiety, emotional ability, irritability, aggression are part of the criteria for the concurrent presence of these symptoms. And that function aligns with the emotional functions of interference with the basal ganglia. The behavior deterioration in school performance has to do with the procedural learning and cognitive functions, as well as the sensory or motor abnormalities have to do with interference there with the basal ganglia. And of course, somatic signs and symptoms of sleep disturbances, urinary frequency, etc., other symptoms that can't be identified. So what we find is not only is these antibodies bind to the basal ganglia, but the symptoms of these patients correlate very highly with the direct correlation of the biological function of the basal ganglia. So let me take a moment here to step back and talk about nomenclature, because sometimes this can confuse people and sometimes this becomes an issue with diagnosis. We know that PANDAS stands for pediatric autoimmune neuropsychiatric disorder associated with streptococcal infection. We also know that other microbes, such as Lyme, mycoplasma, Babesia, Bartonella, and many others we'll talk about, have contributed and do contribute to the same types of symptoms in the disorder presentation. There's the belief that environmental and other biological factors contribute to that. So there are infectious triggers and non-infectious triggers. However, PANDAS only refers to strep. So if you have these disorders, but it's triggered by, let's say, Lyme or mycoplasma, you can't have PANDAS. Therefore, the term PANS was generated. And PANS means pediatric acute onset neuropsychiatric syndrome. Now, still refers to pediatric. So if you're an adult and you have these symptoms, you can't have PANS or PANDAS. So we see terms like ANDAL, autoimmune or adult neuropsychiatric disorder associated with Lyme, and many others. We won't go through all of them. But the point is that we're talking about really a basal ganglion encephalitis or a type of an autoimmune encephalitis, or what we might think of as an autoimmune encephalopathy secondary to infection. And in even more lay terms, we're just looking at an autoimmune dysfunction that resulted in neuropsychiatric and behavioral symptoms that were triggered by an infection. So there is the issue of nomenclature that you have to be aware of, just because we're really talking about certain categories of groups, but we really want to know what the underlying biology is so we can treat that. Now, lo and behold, autoimmune neuropsychiatric disorders triggered by infections are not new. Sydenham, Korea, which was known as St. Vitus's dance, all were exhibiting the same things: abnormal movements, loss of fine motor control, etc. Even in the 1600s, Thomas Sydenham, who this disorder was named after, called it chorea minor. And in the 1800s, Sir William Osler described these as bizarre and percipitive behaviors of children with chorea minor. And we do know that group A streptococci is the causative agents of Sydenham chorea, but the other underlying result is rheumatic fever, of which 30% approximately of those with rheumatic fever will end up with Sydenham chorea. So strep is the causative agent, and it's treated with penicillin or derivatives. And these patients then will resolve with their symptoms and will be treatable as far as that. Now, we don't see a lot of rheumatic fever anymore in the US due to the advent of antibiotics, and particularly penicillin. But in other countries, it still is around. And I'm going to talk briefly here just a second. Here's our research and development. So molecular mimicry, of which why we named the company Moleculera Biosciences, when they attack the brain, This is what we're going to talk about as far as the targets in the brain. This is what we mentioned as basal ganglia encephalitis, autoimmune encephalopathy, etc. We also have an autoimmune cardiovascular panel that's being developed. We know that myocarditis, cardiomyopathy, heart failure, and some of the atrial fibrillation can be due to autoantibodies directed against beta adrenergic receptors, cardiac myosin, and several other targets that are triggered again, potentially by an infection, but result in these antibodies that are targeting the heart. In early development, we have what we call an early identification of autoimmune Alzheimer's, and we're identifying the inflammatory and immune-mediated targets that are triggered to lead to this process of the ultimate eventual deposition of plaques, tangles, etc. Because early intervention and early detection is what's going to allow the successful treatment or the prevention of patients moving on to this disorder. So there is a challenge for those of you who are working in this area and see patients with these autoimmune neuropsychiatric disorders that are secondary to infection. So let's ask the question, why is it that only certain infections trigger this? And why such as strep is associated with pandas and even Lyme and long COVID with SARS-CoV-2? Well, here's the list of bad actors we frequently see, and we're generating a manuscript where we have identified and understand that there are certain types of infections associated with these patients. And the list is here. These typically show up very frequently in patients that are manifesting these symptoms. And one thing to note, it's usually not a single infection, it's multiple infections. So molecular mimicry, as I mentioned, is the process that is one of the most common and believed to be, we believe, is one of the leading causes of autoimmunity. It's really a process when a sequence that's in a foreign and self-peptide are identical and the body makes antibodies against them. So we have 20 letters in our protein alphabet, and in some portion of those sequences, there's going to be a common sequence and a string of common sequences between a part of our body and a part of these infectious agents. And that occurs normally. I won't go into detail about that, but our body has two processes that are known as central tolerance and peripheral tolerance to rid the body of these autoantibodies, or I would say lymphocytes that are produced or will produce those autoantibodies. And that way we don't have what's known as autoimmunity. However, certain patients who have, let's say, genetic predisposition to those particular self, non-self dysregulation will end up with this. So here's what happens. If an antibody is made against a particular portion of this case, let's call it a strep bacteria, and that particular epitope is identical to an epitope on the portion of, let's say, a neuron or a receptor in the brain, once those B cells are made, the plasma cells are producing antibodies, it will cross-react. And this is the self, non-self dysregulation. And that's what's known as molecular mimicry. It has been commonly seen in different areas. This is a strep bacteria, and the commonality between what's known as the M protein with 100 different serotypes and the association with proteins in the heart valve, hence rheumatic fever, and also parts of the basal ganglia, hence Sydenham's chorea. But then you see other things like joint pain and arthralgia and even kidney dysfunction. So the list can go on. If you look through this, you can see Guillain-Barré and Campylobacter jejuni. You see SLE or lupus and Epstein-Barr, MS and measles and EBV, and the list goes on. And as mentioned, long COVID is just really the effect of a virus and a commonality between the virus or the viral proteins and certain parts of our brain, our heart, our lung, blood vessels, and other organs. So to summarize this, molecular mimicry is just really the inability to tell the difference between similarities and something deleterious happens as a result of it. So let's spend some time on the case studies here. And we have many, many of these. So I'll try to go through them fairly quickly, but we have many more than these, but it'll give you a good idea of how the correlation between the presence of autoimmune antibodies and the patient's symptoms and the resolution when the treatment is directed towards the underlying root. So this one is a 16-year-old girl who had severe OCD and tics, and this restricted food intake. So at age 11, she had this food restriction, which really is an OCD. What we're talking about in these cases is the fear of food contamination, the fear of choking, and many other things related versus a body dysmorphia image, tics, choreiform movement, cognitive and academic decline. This unfortunate situation, her behavior prompted 6 calls to the police. So the parents, as you can tell, were very, very distraught. And what we found was that she had one elevated autoantibody directed against and elevated the calmodulin CAM kinase enzyme, which we'll talk about why that's important. And it's the reason we run 5 of these is because symptoms correlate with different autoantibody levels. She had relapsing remitting. There was an autoimmune disease, sort of not otherwise specified. Her diagnosis resulted in some lab tests where she did have a positive Lyme test, elevated mycoplasma, and Coxsackie virus titers. And the family history was very interesting because there was autoimmune disorders in the family and a history of rheumatic fever, and the siblings, interestingly, ended up having pandas. So the treatment based upon the test results in the patient history was plasmapheresis and IVIG, again, removing the offending antibodies, replacing it, and having immune modulatory effect. They had some low-dose Zoloft and Abilify, but the patient dramatically improved. We retested her, and her CAM kinase returned to baseline. In another case study, this younger girl who was 8 years old exhibited various types of neuropsychiatric symptoms. They were heterogeneous, obsessive compulsive behavior, emotional ability, and dysgraphia, and then, of course, sleep and urinary problems. This patient had both her lysoganglioside and tubulins elevated and a borderline dopamine D1. And so there's various symptoms associated with that. This, of course, was relapsing and remitting. Her diagnosis was anxiety, OCD, and then the unspecified immune disorder. Interestingly, she did not have positive ASO titers or DNase-B or things you would think with a strep infection. But strep can occur in many orifices of the body. And what they found, though, from the history was she had 2 recent streptococcal infections, sore throat, sinus pain, cough, frequent ear infections, sinus infections, and just idiopathic fevers. So the family history was positive for mycoplasma and autoimmune disorders and frequent bacterial and viral infections. So this would make you think that there might be something going on here that was infectious triggered. The treatment in this case, which was caught early, 1 course of azithromycin, the patient rapidly improved in symptoms, and all of her symptoms returned to baseline. And this is her post-treatment test results. Her lysoganglioside returned to baseline, her tubulin returned to baseline, and even the borderline dopamine D1 returned to baseline. A 20-year-old young girl with OCD and neuropsychiatric symptoms, multiple symptoms. Again, you can see the commonality of these, which makes it difficult to diagnose because sometimes the patients are often thought of as maybe conjuring up these different types of symptoms, or maybe that the parents, or often sometimes these can go awry as far as this because of the different symptoms. In this case, this patient had an elevated dopamine D2 and an elevated calmodulin CAM kinase. This was also relapsing, remitting, and aggravated with flares, diagnosed with idiopathic peripheral neuropathy, but they also did find Lyme disease and then gave her a diagnosis of an autonomic nervous system. She was also positive for strep when they looked for the infections, babesia, mycoplasma, EBV, herpes zoster, etc. So the medical history was frequent strep infections since childhood. Low IgG, sometimes we see this in patients who have immune dysfunction, and then dental infections. And the family history had autoimmune diseases. We do see that in about, let's say, somewhere between 75 to 80% of patients, they will see a family history of autoimmune disease. This one required some aggressive treatment, but very successful. Treatment with rituximab and some ozone treatments, significant reduction in symptoms, and as what you can see is her dopamine D2 autoantibodies return to baseline, as well as the calcium calmodulin CAM kinase. This one here, I'll just kind of quickly go through. Again, another individual, 17-year-old young man. In this case, he had a positive CAM kinase. Symptoms treatment was NSAIDs. And in fact, sometimes a course of NSAIDs is kind of a canary test in the mind to see if they are responsive, and multiple IVIG infusions. And what they saw was rapid improvement, and the patient's calmodulin CAM kinase returned to baseline. We'll summarize this and wrap it up here. This one is a published study by Dr. Bernstein and his team. He is an immunologist at Cincinnati Children's. This was a 15-year-old girl who had been diagnosed and treated unsuccessfully for schizophrenia. She had psychosis, anxiety, depression, and they were going to put her back into a treatment facility. They called in Dr. Bernstein, who's an immunologist, and he knew about the autoantibodies and the potential. He tested her and reported the results that she had elevated dopamine D1 antibodies, D2 antibodies, lysoganglioside, and tubulin, and borderline calmodulin CAM kinase. He treated her with one course of plasmapheresis, and the patient had complete resolution of her psychiatric OCD and anxiety. He weaned her off of olanzapine, and he said within 2 weeks after plasmapheresis, she was playing tennis, and the response has been sustained for 6 months, consistent with studies. So we read this and contacted him and asked for a sample post-treatment, and we did indeed find that all of her elevated antibodies had returned to baseline. So we really do see, after 16,000 patients in these tests, we find that there's a direct correlation. When they have autoantibodies against dopamine D1, we do see various types of psychiatric symptoms, whether it's mood swings, depression, anxiety, irritability, aggressions, and occasionally we'll see a psychosis. Patients, when they have antibodies against dopamine D2, often will see frequency of some level of a movement disorder, like choreiform movements, or maybe a diagnosis of ADHD because they can't sit still. And we're seeing many patients who have been actually diagnosed with Parkinson's. And so there is a correlation here with some of these antibodies. When they have lysoganglioside GM1 autoantibodies, we find that they complain of joint connective tissue pain and other types of tics. We do see a high frequency of anti-tubulin autoantibodies. This one seems to be more common. Tubulin is an intracellular protein highly concentrated in the brain cells, and we see that they frequently complain of OCD, and often they'll describe this as brain fog. We'll also see food phobia, phobias around clothing, other intrusive thoughts. And then this is a functional assay, meaning we grow up human brain cells, not the patient's, but the human brain cell line in culture. We incubate the serum to see if any antibodies will bind to the human brain cells. We do then pulse chase it with P32, and we're looking for the activation or the stimulation of calmodulin CAM kinase activity. Why is that important? Well, this particular enzyme actually is involved in the upregulation of three neurotransmitters, epinephrine, dopamine, and norepinephrine. So in these cases, an antibody is calling for the increased expression of neurotransmitters, which you don't want. And as a result of that, correlating symptoms, we see fight or flight behavior, activation of the autonomic nervous system, anything that looks like easily startled, separation anxiety, mydriasis. And one interesting correlation, although this is not a test for an infection, typically we do see an association with active infections or recurrent infections. So there's numerous studies that have been published, which is one of our goals has been to try to document and then work with collaborators and get these out in print so that more will understand the connection. And as I mentioned, that it's very important to be able to use precision medicine and clinical diagnosis to be able to separate these patients so they can be effectively treated quickly. And on our website, we have multiple stories. This one is a Grace who was diagnosed with ADHD and OCD. And if you can believe this, she was diagnosed with a mental disorder at 8 years old, and she was trying to kill herself. Parents emptied their 401k twice. And so they found out, the doctor found out about us. They ran her test. She was positive. They treated her. And not too long ago, her mom sent us this picture of her completely well, back to normal life and on the cheer team. Another one, Adam, who was diagnosed with ADHD. Then they thought he had autism, and they were going to put him into an institution. They actually happened to move into our state, and then the clinician they work with knew about our work. They ordered the test. He was positive. They treated him, and not too long ago, she sent us this picture of him running cross country, saying recovery is possible. He's 10,000 times better. So let's summarize. What are some of the commonalities of patients that are positive when they're run in the autoimmune brain panel and looking for autoantibodies or these anti-neuronal antibodies and CAM kinase activation? Treatment resistance to standard neuropsychiatric drugs is one. Frequency of infections, as you saw in the case studies, but remember, infections can also be subclinical. Sometimes they'll be diagnosed with neurologic Lyme or post-treatment Lyme disease. And as you saw in many of these cases, there's a family history of some autoimmune disorder. And one of the hallmarks of PANS, PANDAS, or the like is this sudden onset or acute onset of neuropsychiatric symptoms. Now, they aren't always sudden onset, but in order to be diagnosed with PANS or PANDAS, they have to be sudden onset. But we do see gradual onset and very similar recoveries of patients who are being treated for these underlying infections and autoimmune conditions. Sudden rapid onset of obsessive compulsive disorder, and this restrictive eating disorder, which sometimes could be diagnosed as anorexia. And we're doing some work with some clinicians who are in these eating disorder clinics, and they are finding when they test many of these patients that there is a percentage of them that have antibodies, these autoimmune antibodies directed against these targets. Vocal or motor tics, choreiform movements, you saw the anxiety, rage, etc. And then depression. We just recently had an adult of 70 years old, sudden onset of depression and preceded by an infection. So they're currently being tested. So we do see adults and children that are positive. Dilated pupils, maybe 30% of the patients will exhibit this more frequently when they're positive for the calmodulin CAM kinase. Relapsing remitting. We have a pediatric neurologist who sees many, many, many patients, PANS, immune-mediated neuropsych, and she said every single one of them, without exception, if you ask them correctly, or at least in a way in which they'll feel free to tell you, they have experienced suicidal ideation. So it's important to recognize that this is actually a common occurrence. And unfortunately, we have worked with and do work with a number of those after the fact, unfortunately, where they have taken their own lives by suicide. So do be aware of this as being a potential comorbidity that happens. PANS, obviously. And so what are the takeaways? Well, it's important to get a medical history. This is where you'll find whether there's family history of autoimmunity, frequency of infection, treatment resistance of these neuropsychiatric disorders, etc. And gradual onset can be really sudden onset, but forgotten many years ago. Relapsing remitting, family histories, as mentioned, eating restrictive disorders, obsessional fears, choreiform movement, which is really the piano playing finger movements. One of the clinicians we work with says that what she does is she has the patients close their eyes, hold their hands out, and then see if they start moving their fingers uncontrollably. This is the choreiform movement. Dysgraphia, tics, mydriasis. There's labs that you can look at, strep testing, but you remember that they weren't always positive. ASO is non-specific, but sometimes that can occur. ANA, and do search for infections. We talked about other occult infections. And of course, the autoimmune brain panel that we're talking about can be a really helpful, definitive, or at least I should say confirmative, because PANS, and all these others are clinical diagnosis, but you would like to have some type of biological evidence. So if we were to summarize the diagnosis and treatment and what you would do once a patient has a positive or is clinically diagnosed correctly with this, you do want to identify and treat all infections. And I say infections because our studies have shown that often it's more than one, and patients become susceptible when their immune system is compromised. Then treat the inflammation if the patient hasn't completely resolved, and the inflammatory pathway. And if they don't completely resolve, then treat the immune system and any dysregulation in the immune system, while remembering that they may need symptomatic relief as necessary. Some clinicians will provide a very low dose SSRIs because of the need to maintain or contain or help the patient. And low dose meaning very low, and slow because standard doses, they actually can be worsened. So if you think of the three I's, look for infections, inflammation, the immune dysfunction, and treat those three. But also remember that as a result of often these long-term components that they've been suffering with, you'll get metabolic dysfunction. You can see gut dysbiosis. And when patients are being treated for this, you can see the Herxheimer reactions from the die-off. But remember, when you're addressing these things, there is a process, but you need to address all of them. So if you're interested in ordering and testing these result processes, as I mentioned, we have now tested over 16,000 patients, literally in almost over 50 countries, and about 2,800 clinicians who have placed orders. There's a lot of things we have learned over the years because we're the only laboratory in the world that runs these, and we do provide consultation and support in the process. So we do require a ordering clinician to order the panel. It will come to us. The price is $9.95. We do require a $4.95 deposit, and then we will then process, and it'll come to us by FedEx. It will come to our laboratory. It will take 2 to 3 weeks to completely run all 5 of these. And then once they are run, they will be reviewed and put up in a secure HIPAA compliant portal. You will be notified, and then we will bill the insurance of the patient as a courtesy. And we do get reimbursement on about, of some form, about half of the patients. And then we do have online report access. And then Amy, who is our moderator here, and another nurse are available to provide consultation and support on test results. So as I mentioned, we do provide in-service webinars for your office staff. We provide direct support for you, clinician, on your patient laboratory results. We do have more resources, publications, videos on our website. If you'll go to www.moleculera.com, you'll find a wealth of resources there. And then if you have patients who want to ask us questions, they can call the direct office number. We can talk to them about blood drawing stations or some basic information about the panel and about insurance coverage and payment plans. They can contact us directly. And also, if you want to hand out anything to your patients and maybe let them just do the research, we have downloadable resources, and we can send out hard copy educational brochures at no cost. So in summarizing all of this, getting to the root of these disorders is really important. And I've adapted what Dr. Sidney Baker called his TAC laws. The first one is if you're sitting on a TAC, the treatment is not 2 Advil every 3 to 4 hours. TAC sitting, the treatment is TAC removal. And the takeaway message is, if you look for the root and you treat the cause, you'll have more effective results than if you treat the symptoms. And then the second TAC law, which is if you're sitting on 2 TACs, removing 1 TAC doesn't eliminate 50% of the symptoms. So the takeaway is complex conditions are complex, and you do need to treat all the underlying issues. And again, the 3 I's: infection, inflammation, and the immune system. So to be effective, address all the underlying issues. And we believe that you'll see, as we have, and many others have, remarkable recoveries of patients who have, in many cases, suffered for years and in some cases, decades. So I'm going to wrap it up there. I know we covered a lot. We have a lot more information available, and we're happy to share that with you. But our goal is to change how medicine is practiced for these immune-mediated inflammatory disorders. And I do want to thank you for being at the front line, where you're the ones who are actually taking care of these patients, and we're here to help you. So, Amy, I'll turn that back over to you.
Okay. Thank you so much, Dr. Shimasaki. As often as I have heard you speak, I learn new things every time. So thank you so much for that. We have now an opportunity for Q&A. And let's see, we look in our, don't see anything. You must have covered everything very, very thoroughly, because I don't see any questions at this time. The opportunity to ask questions is not limited to the webinar. Our email, we have multiple email addresses that you can use. The quickest one to get to clinical staff is medical relations, all one word, at moleculera.com. And here's a question. Are there plasmapheresis options that you can help a doctor with who asks this in Europe?
Yeah, that's a really important and interesting. At the time, I don't know of any, although there are some, and I think that's going to be something that we really should look into. I think as more and more of this diagnosis is becoming more well understood and known, that because plasmapheresis is not novel per se, It's just the use for this that there will be, and there should be more. But at the moment, I'm not knowledgeable of those, and maybe we can help with the research on that. And I think that's from Jillian, our partner in Europe at AONM, who also helps with many of these things. So maybe we can collaborate and look and see if there's some places or not.
Dr. McLaurin has a question that we frequently hear about resources for helping our prescribers find IVIG resources in their locale. And we do, Craig, you might want to mention our collaboration with Solio in that regard.
Yeah, so we do have a partnership that we work with back and forth, referring patients and clinicians and different types of resources for IVIG. Solio Health, and we can get you a particular individual who can not only help with identifying that, but get you help with, in many cases, the insurance filing, the reimbursement, those things for the clinician. So you can email us or email Amy, and we can get you in contact with the right person, because we refer back and forth because that is one of the things that we do find that's frequently requested.
Yes. In the absence of any further questions, Dr. Shimasaki, let me ask you if you have any summary statements you'd like to make before we close.
Yes, thank you, Amy. A couple of things. One, first of all, thank you for being at the front line and taking care of these, what others might call difficult patients, but they are patients who desperately need help. And we have seen story after story of, once they find the right answer and work with someone such as yourself who is willing to work and take the time to understand it, that there's great relief, and there is also some remarkable recovery. So we thank you for that. The second thing is that we do a lot of research, and we do a fair number of case studies and clinical studies, as you saw. We're still a very small company, and even though the pricing of the test is almost $1,000, it still doesn't cover our costs. So one of the things that we do is we do research to help understand and share this information in publications. So if you're interested in a case study in which, as you saw, some of the pre and post studies that we could publish together and work in to share that information with other practices, do contact us, and we'll be happy to work with you. So someone says they have a question there too.
There is a question from Dr. Pacito in Italy, and I am responding to her directly in the chat because she is needing to connect with our wonderful partner in London, AONM, and I think that will be very useful for her. So I'm just typing in that address for her. Otherwise, I think we're finished for today. And I thank you again, Dr. Shimasaki, for this wonderful lecture. I know we all benefited, and I look forward to connecting with our attendees in the future to make sure that their needs are met, regardless of what they are, whether it's ordering, enrolling, interpreting, whatever their needs are, we'll do our best to help them. So thanks very much.
Thank you, Amy. Bye-bye.
Bye-bye.